All right. So once again, I'm going to talk about MIS applications in deformity surgery. So this kind of represents my evolution of surgery. So a few years ago, I started road biking, and then I bought a tri-bike. And I thought it was pretty cool. It was pretty fun. It's fast, kind of hard to handle, and I like going fast on two wheels. So then I rode my buddy's Vespa, and I thought that was a lot of fun too. And the next thing I bought after that was this BMW race bike to take on tracks. So the evolution went from a bicycle to a race motorcycle, and that's what spine MIS surgery has been for me. When I trained and I did my fellowship, we didn't do any MIS procedures whatsoever. And luckily, I have some great partners that helped me learn how to do MIS procedures, and started with discectomies, lamies, one-level fusions. And the question is, would it be beneficial if we apply this to deformity surgery? And also, can we successfully apply it to deformity surgery? So the first thing is, would we want to do MIS deformity surgery? What's the benefit of it? And there's a huge benefit of it when we look at the complications that we have with traditional open adult deformity scoliosis surgery. So Glassman did a paper, and they reported an 8% incidence of major complications. And that's on the low end of all the reports. And they talk about major complications being PE, death, and more than 4 liters of blood loss. So it's pretty significant. Auerbach did a study where he looked at what leads to complications. So if patients have more than 3 comorbidities, a pre-op SVA greater than 40 millimeters, or an age greater than 60, these are significant risk factors for complications. If you look at the patients that you operate on for adult degenerative scoliosis, all of my patients have more than 3 comorbidities, SVAs are more than 40, and they're usually older than 60. So high complication rates with these kinds of surgical procedures. Neil Anand did a paper with Todd Albert, and they reported a 70% incidence of complications. And some papers report up to 100% complications when you take into account minor and major complications. So the potential advantages of decreased exposure-related morbidity is decreased bleeding, decreased post-op pain, hospital stays, and faster recovery. So now we've clearly demonstrated that there is a potential benefit of MIS surgery, but can we use these MIS techniques to successfully achieve the results that we want in deformity surgery? So what are the main goals of deformity surgery? Number one is to decompress the neural elements. And we can do that with either a direct decompression through MIS, lamies, and TLIFs. That's been proven in the literature to be helpful, successful, decreased blood loss, decreased hospital stays, and decreased pain management, pain medicine usage. And also indirect decompressions, whether it's through a lateral interbody fusion or an ALIF, has been shown to help with neural compression as well, both foraminal and central. So we know that we could decompress neural elements. And the other goal that we have with deformity surgery is establishing global sagittal alignment. You started a great talk on that. So I can skip through the majority of this stuff, but essentially the cone of balance is that top picture. If you're out of that cone of balance, you need an assisted device to stand upright. If you're within the cone of balance, you can stand upright by retroverting your pelvis, like the last talk clearly demonstrated, and flexing your knees and your hips. So things that we look at are pelvic tilt and truncal inclination. It's really important to have these restored as close as normal to have a good outcome, clinical outcome at the end of your surgery. We just went through SVA, pelvic incidence, pelvic tilt, and sacral slope. We also talked about why pelvic retroversion, like you can see in this case, leads to pain, because you're using your pelvic muscles to retrovert your pelvis to get better alignment. And that's an active procedure, and it leads to fatigue and pain. So the question is, can we achieve global sagittal balance with these MIS approaches? The standard minimally invasive surgeries that we do are TLIFs, lateral interbody fusions. Some people, who does axial lifts over here? Who revises axial lifts over here? Yeah. So some people do axial lifts, that's why I put it up there. Facet fusions and percutaneous pedicle screws. And when we do an MIS deformity case, it's typically a combination of these procedures. This is a paper by Neil Anand that he published in 2008. I remember reading this paper in 2008 and thinking this was the most foolish paper I've seen, right? So here's someone that doesn't have a big deformity, and here are screws with an axial lift and multiple level laterals and T-lifts. I remember making fun of this paper at a journal club, saying that this was MIS vomit. It's just an overkill of procedures. But in actuality, I think it was a great paper in retrospect. I think it was a good feasibility paper. So I don't necessarily think it was needed in this case, but what Neil showed is that you can use MIS techniques, combine them, and apply them successfully to deformity patients or long constructs. So when we talk about deformity techniques for MIS techniques for deformity, there are 3 main categories. You can do circumferential MIS, which is essentially standalone lateral interbody fusions or lateral interbody fusions with perc screws in the back. You can do a hybrid procedure with lateral interbody fusions with an open posterior procedure, or a regular open traditional procedure with osteotomies only, posterior work being done. So the two MIS techniques that are used the most in deformity surgery are percutaneous pedicle screw fixation and lateral interbody fusions. So first, let's talk about percutaneous pedicle screw fixation. I think most people in this room feel fairly comfortable with it. The question is it safe? So there are many papers showing that it's safe. There's one paper that had 131 fractures treated with almost 700 screws. They had 16 violations, and none of the patients had neurological symptoms, so that's pretty safe. Mobs did a paper. I'm more worried about guide wire advancement when I do this with guide wires, and they essentially show that they had 7 guide wires advanced anteriorly with 525 screws placed, and no patients had abdominal and visceral injuries. So it is fairly safe. But both those papers are in the trauma setting and in the adult degen setting, not in the deformity setting. So who uses percutaneous pedicle screws in deformity cases? Anybody? So it's all based on imaging when you're putting in a percutaneous pedicle screw. So it's really hard to get an AP and a good lateral. And if you can't, like another speaker pointed out, if you can't see what you're doing, you shouldn't be doing it. So you need a good fluoro image, and that requires manipulating your C-arm so you can get a good AP and lateral. So here's a good picture. The progression of the slides goes from left to right. Basically, by rotating your C-arm, you can see how you can take that image on the left and get a good AP all the way to the right with the spinous process centered around the pedicles. And same thing on the lateral. You essentially want one overlapping pedicle. And if you have good AP and good laterals, then you could percutaneously put in screws. Because it's a scoliosis case, you're going to have to adjust it per level. So that's a lot of C-arm manipulation, and it's also a lot of radiation, which is a negative of doing this procedure. There was a paper that Mike Wang was a co-author on, looking specifically at the safety of pedicle screws in deformity settings as opposed to the previous papers. And they put in 410 pedicle screws in patients with at least 10 degrees of rotation. They used something called an AP-only technique where only one single C-arm was used. And not advancing. There we go. And basically, they showed that 2 screws needed to be repositioned, but the rest were fine. And the screws that needed to be repositioned were for only a sensory deficit, so no motor deficit. So they essentially showed that putting in percutaneous screws in adult deformity patients is safe, even though there's rotation. Can you advance for me? It's just not clicking from here. Sorry about that. Is this battery or something, or should I just say next? All right, so we know that we could put in percutaneous pedicle screws with MIS techniques. Now the question is, are lateral interbody fusions useful in these techniques? So the main question that we have to ask ourselves are, what does the literature say? Because we all have cases that we do, and we look at our post-op films, an N of 20 or an N of 30, and we say, oh, it works. But that's just anecdotal medicine, right? It's not really good medicine. So if you look at the literature, what does the literature really say about the role of lateral interbody fusions in the setting of adult scoliosis? Next slide, please. So there was a good systematic review that was recently published in 2014 that asked just this question: what's the role of minimally invasive lateral lumbar fusions in establishing sagittal coronal balance? And in the systematic review, they had pretty good exclusion criteria, as you can see listed above, and they found only 14 papers that addressed this topic, specifically talking about sagittal balance. Of these 14 papers, 12 were retrospective and only 2 were prospective, and those prospective papers were cohort. They were not prospective randomized studies. So the level of evidence is not that great in the literature. Also, when you look at all these 14 papers, they mentioned sagittal alignment, but only 2 of these papers spoke specifically gave you specifically numbers in terms of SVA reduction. Otherwise, they basically said sagittal alignment was improved, but they didn't give you specifics. Next slide, please. So the 2 papers one of the 2 papers that did actually mention the actual numbers of sagittal alignment correction was by Acosta. And this is a retrospective study looking at 36 patients. Only 8 of these patients had degenerative scoliosis, and they had VAS and ODIs for clinical measures. In terms of their radiographic measures, they looked at the coronal Cobb angle and the sagittal, segmental, and regional Cobb angles, as well as the overall SVA. As we expect with lateral interbodies, they had an improvement of the coronal Cobb angle, and their clinical scores were improved. Next slide. and this is just a picture showing you what their lumbar lordosis was. So the lumbar lordosis was significantly improved. Sweet, thanks. So the lumbar lordosis was clinically improved, but there was no statistical change in the overall sagittal alignment measured by SVA. So they essentially showed that lateral interbodies did not help correct their overall sagittal alignment, even though it did correct their regional lordosis. So there was another paper that was published recently. I'm not even going to try to pronounce the author's name. It was essentially about anterior column releases. Whoever here does anterior column releases with their lateral interbodies? Anybody? I've accidentally done a couple of anterior column releases, and I don't do anterior column releases regularly, but I think I'm going to start incorporating that into my deformity cases. So in this study, they did anterior column releases in 7 patients, and they placed in a 30-degree hyperlordotic cage as opposed to the standard lordotic cage, and they put posterior instrumentation in all these patients, and they showed that their segmental lordosis increased 17 degrees per level. But more importantly, they showed that their SVA decreased by almost 5 centimeters. That's huge, and their pelvic tilt decreased by 7. So I mean that's a pretty significant number. This graph over here is just a bar graph showing the improvement in lumbar lordosis, SVA, and pelvic tilt. And this is just a radiographic picture that they had. So anterior column releases seems to be beneficial. That was just a small case series, but there was a decent retrospective review that was published recently with 36 patients. And they had 2 groups of patients, the ones that had anterior column releases and lateral interbody fusions, and the ones that did not have anterior column releases. And they recorded the data for both stages of the procedure. So the first stage was a lateral part, and the second stage was a posterior part. And they found that they had a 12-degree improvement in segmental lordosis and a 3-centimeter improvement in SVA per anterior column release level that they did, which is really impressive. So they actually got some good correction. And those numbers are comparable to what an SPO can get you. So if you look at this, it's just a bar graph. If you look at the brackets on the top, they show you which results were statistically significant. This is the non-ACR group, and this is the anterior column release group. And SVA was only statistically significant in the ACR group. This is a busy chart, but it's fairly interesting. This is pre-op, and this is after the whole surgery is done. And this is after the lateral releases, and this is after the percutaneous pedicle screws are placed. So essentially, it shows that in the ACR group, there was a significant improvement in the SVA, statistically significant, from pre-op to final post-op. Now, the interesting thing over here is if you look in this column, there was really nothing statistically significant with the addition of percutaneous pedicle screws, meaning all the correction they got in their Cobb angles, lumbar lordosis, and SVA all came from their lateral interbodies, and the pedicle screws didn't add anything to it. Which raises the next question: what's the role of percutaneous pedicle screws with lateral interbody fusions? Can you just put in a bunch of standalones and be done with it? So Frank Phillips looked at this, and they did a prospective multi-center study where they looked at lateral interbody fusions with and without instrumentation, and they found that your correction was better maintained with percutaneous pedicle screws than without percutaneous pedicle screws. More importantly, there was a paper by Malman, and they looked at the maintenance of segmental lordosis with standalone interbody fusions, and they found there were several parameters that led to settling, and these were osteoporosis, instability, and if you put in laterals for more than 2 levels. Now, this is relevant for this talk because pretty much everyone that we do these procedures on are osteoporotic. They have some level of lateral listhesis or antral listhesis, and we do more than 2 levels. So in the specific case of adult deformity surgery, it's always advisable to put in posterior percutaneous pedicle screws. So there's something called a ceiling effect. There was the International Spine Study Group. They wrote a bunch of papers recently from their pool of patients that they've collected, and this was a retrospective multi-center study. And they found that they looked at 3 types of surgeries. They looked at the standalone laterals, circumferential MIS, and a hybrid group. And they found that there's a ceiling effect, no matter what technique you use, for how much correction you can get, both in the coronal and sagittal plane. So what are the limitations of MIS surgery and deformity? Well, one of the big limitations is that deformity corrections typically occurs via the interbody technique. So you're not using osteotomies as well. There's a decreased ability for in situ bending. So since you're percutaneously passing the rod, there's no more in situ bending. So your sagittal correction is more limited. And if you don't do good interbody work, like we've talked about already, there's a concern for pseudoarthrosis. Other concerns, radiation exposure. Whoever does MIS surgery here knows that we use quite a bit of radiation, and it's a big concern for me. Time, it takes a long time if you have to adjust the C-arm for every pedicle screw you're placing in a deformity case. And also cost is a significant issue. This is debatable because there are some papers showing that MIS surgery is cost savings. It depends on what you're quantifying. Is it just hospital stay, or if it's the whole post-operative period? It all depends, but cost can be a concern. So because of these limitations, it's important that we select the right patients for MIS surgery. And these decisions should be based on someone's symptoms and also their radiographic findings. And these are based on standing Scully films, dynamic x-rays. These are both essential x-rays to get. So the same International Spine Study Group came up with this algorithm. And this algorithm is supposed to help us determine what type of procedure to do on someone. The algorithm essentially looks at several key radiographic parameters, SVA, pelvic tilt, and the lumbar lordosis PI mismatch, all things that we spoke about just recently. And here's the algorithm. It's pretty complicated looking, but it's relatively straightforward, meaning if someone's fairly well balanced and if they have a relatively small pelvic tilt, and if their global sagittal alignment's okay, you can just do a small MIS procedure on the one level that's affected. If they have a flexible curve, or if they don't have a fixed deformity, you can go ahead and do MIS surgery with decompression and interbody fusions at the apex of the curve or the whole Cobb angle. If they have a fixed deformity with a large SVA, you want to do something open. So they get divided into class 1, class 2, and class 3. So here's a case example. This is a 63-year-old woman, leg pain. She failed conservative management, can't ambulate long distances, normal exam. She clearly has some central stenosis over here. Look at her films. She's got a little bit of degen scoliosis, really not a big deal. Her overall alignment's pretty good, so she would be a class 1, right? So for this lady, she can just have a small MIS TLIF and be done with it and be happy. So here's the other extreme, right? Here's a guy with a really big SVA, big deformity case, fixed deformity. So this would be a class 3, right? So this isn't someone that you're going to do an MIS TLIF on. This is someone that benefit from a bigger procedure. This is a regular open PSO. And this lady is a 62-year-old woman with severe back and leg pain, normal exam. She's, over here you can tell her pelvic tilt is huge, sacral slope is minimal. There's no thoracic kyphosis, and she's really extending just to stand upright. So this is a class 2, and this is a combination of laterals and percutaneous pedicle screws. So this algorithm is a good starting point, but you have to take each person into consideration. But it's worthwhile to look at this algorithm and think about these parameters before you decide which approach to pick. I mean, when you come to a talk that's minimally invasive based, you seem to think that you should do everything in your practice minimally invasively. It's just not true. I probably do half mine open and half mine minimally invasive. Another thing that I mentioned briefly is radiation. I'm really concerned about getting radiated, whether it's posterior pedicle screws or lateral interbody fusions. So we started doing laterals with navigation. How many of you guys are doing laterals with ORM or some other form of navigation? It's really changed our practice significantly. So this is the setup. You can't use the standard Skytron bed because the arm doesn't fit underneath. So we use a regular spine table. You could put a bump there, or now I use an Allen bow frame and bring in an arm, and we navigate all our levels. We start at the most cranial level and work our way down. And basically, you put a tracker into the ASIS, and then you could navigate all your levels, and you could do multiple levels really safely. With really no radiation. You have a C-arm in there just to take spot shots on your lateral because the Cobbs and curettes aren't navigated yet. But this procedure can be done really safely. You just, yeah.
You see any slope in your patients though with the tracker over time if you do multi-level laterals?
No, so the concern is that, so when you get your initial image, the patient's in one position, right? And then you put in an implant, that position changes a little bit. So how accurate are you going to be, right? So that's a concern. And we don't need it to be accurate to the millimeter where we are, right? So if you're a little bit off, it's fine. And we've done about 25 patients this way, and we haven't had any issues with our cages. Something I do is when I take my spot shot with my fluoro, when I'm cobbing and curetting, I make sure that it matches my navigation. So let's just say I'm doing a L1, 2, 2, 3, 3, 4, 4, 5. I'll just make sure that when I'm curetting and I'm in the middle of the disc space on my C-arm, that I'm also matching it on my navigation. So it's really not been an issue.
You kept track of your time?
Yeah, we're getting the data together to publish right now in terms of time and also radiation exposure, how many shots we take with the fluoro. We're going to submit that for publication pretty soon. Bless you. So same thing with pedicle screws. You can place them in without K-wires. Admittedly, I don't do enough of this. I started doing K-wireless screw placement. But once again, you can save yourself a significant amount of radiation, and you can achieve the same results. So in summary, MIS approach is not applicable to all deformities. The algorithm is a good algorithm, but it should be individualized to each patient. And you should consider using image navigation for not just for safety, but also to save yourself the radiation exposure. Thank you very much.